We're thrilled to have Dr. Kate Mulligan here with us today to continue our theme of celebrating and continuing to build connections, to forge new ones, to strengthen existing ones. We know you know everyone in your project, but perhaps there are other connections that can be made in person here. So Kate's celebration is titled Celebrating and Scaling Community Leadership in Mental Health. And she'll emphasize the significance of the equity-driven MH-COVID initiative to mitigate the impacts of the pandemic while also building more resilient communities. So Dr. Kate Mulligan is an assistant professor in the Social and Behavioral Health Sciences in the Dalai Lama School of Public Health at the University of Toronto. Dr. Mulligan is the Senior Director of the Canadian Institute for Social Prescribing, the Director of Policy and Communications at the Alliance for Healthier Communities, and a member of the Toronto Board of Health. Kate is an expert advisor to the Canadian Red Cross in the areas of collective impact, community health, and social prescribing. There's a theme here with social prescribing here. She is globally recognized expert in community approaches to health and well-being, and she has led one of Canada's first social prescribing pilot projects. So please welcome Dr. Mulligan.
Thank you so much. And so while we're setting up, take a minute to stand if you need to, stretch, move your body. You did the social warm-up, but you might need just a bit of a physical, I know I do, right? Physical warm-up. Thank you. Take your time. Hi, I am so thrilled to be here celebrating with you after, I'm really loud, so you might need to turn me down. So celebrating after 2 years of hard work and grit and challenges and big successes. And I want you to know that I read every single one of your program descriptions on the KDE Hub website, and I'm a big fan. So thank you, merci, Chimigwech, for having me here with you to help celebrate and to set one of the tones for the next 2 days in challenging you to really think about scaling up, sharing what you learned with one another, and thinking about our 40 projects. What would it look like if we could tell the decision makers at FAC or back in our home provinces and territories or other parts of the world, what did we accomplish in aggregate together as a community? What if we could share the outcomes and outputs of our projects collectively and demonstrate that times 40, we made a difference, and we're going to continue making a difference. That's what I want to talk with you about this morning. So I've worked in community health and public health. Some of those roles that Al shared are behind me now. I sat on the Toronto Board of Health during the COVID crisis and pushed for community leadership and community supports and equity, and struggled alongside you. And I know from my own experience and from my research that communities who face barriers to accessing health and health services, barriers to equitable access to the social and structural determinants of health, are often ignored. Not in this room, but in many rooms, in most rooms. Even when they're prioritized, sometimes we see their deficits emphasized over their strengths, or have knowledge excluded without reciprocity, right? People come and learn and leave. Or we see exclusion from those feedback loops in advocacy and policy making where I work. They're not even welcome, not even part of it, don't even know how to access those loops that privilege already powerful people, already powerful politics, already included perspectives. That's your context. So I'm not telling you something you don't know, but I want you to know I empathize with that challenge. How do we change this? These are what the World Health Organization calls the 6 building blocks for health systems: service delivery, health workforce, health information systems, access to essential medicines, financing, leadership, and governance. And they ideally will lead to some good health outcomes. Does this satisfy you? Does this represent you and what you do? I don't think it does. It's time for us to share what we do in a way that takes us beyond those building blocks. And so this is one model, and I've put references at the end of this slide deck, and you will all have access to them so you can see and give due credit to all the folks who have come up with some of these images and diagrams that I'm going to be sharing with you. This is a model of what it could look like if we went beyond those building blocks. So the sort of orange color shows those traditional building blocks: service delivery, workforce, and so on. Yes, they are important parts of health systems. But excluded from that is everything outside of that: the social determinants of health and mental health, household production of health. We know that the work of caregivers, unpaid caregivers alone, is propping up our health system, and our entire health and social services system would be toast by noon on the first day if those unpaid caregivers stopped doing what they do. And I didn't invent that statistic, by the way. That's something that's been widely shared for Canada by the Canadian Centre for Caregiving Excellence and researchers. Community organizations like yours, societal partnerships, the work of community-based trained health workers, volunteer and paid, and the community-based health promotion and healthcare services like the ones you provide. And really incorporating that too into the information, learning, and accountability of our systems. This is what you're doing. This is what you have done. We need to take it from the blue and make it part of the orange, make it part of what we recognize as a regular contributor to the system, because it is. And there are many reasons why this work has been marginalized, right? There are some historic reasons of colonialism, for example. We inherited a colonial system that was built for a very specific group of people, and it wasn't most of us in this room. And we still have the same systems. Provinces are in charge of healthcare. Why is that? Confederation. Health happens in hospitals and by entrepreneurial MDs. Why is that? Well, Confederation. Like a lot, so we've still got some of these systems. They're not inherent. They can be changed. Okay, there's maybe been one significant innovation since then. That was Medicare, 100 years later. So yeah, we got Medicare now. Okay, so we got 1867, we got 1967, 2067. Can we get community in there? Can we get community health a recognized part of our health system? Okay, the work is racialized. The work is feminized. The work is devalued. But the care economy is not going away. It's getting more and more important. And the work we do is so vital. And one of the most significant ways to make this work sustainable, and I mean financially sustainable, ecologically sustainable, emotionally and mental health-wise sustainable, like, can we keep this up? We have to make it part of the regular system so we can rely on it, so that your funding goes longer than 2 years, right? But one of the most important ways to do that is to share our story and to share it together, because there is a perception, in some ways reflected by the current reality, that community health work is a series of pinpoints all over the place that don't add up to something more than the sum of their parts. And we're here to challenge that and to find the ways in which we do add up to more than the sum of our parts. And we are a sector, and there's a really important contribution that we're making. Okay, so how do we do this? This is from a framework called the Waters of Systems Change. Look, academics like me we're good at the mental models, all right? We'll just tell you, just transform it. Just do something that's completely different. Why don't you just put community health first? Well, we would like to do that. We want that transformative change, but it doesn't happen overnight. I mean, occasionally we have those revolutions, right? Okay, so we've got 2 so far, going for the third one, 2067. Structural change, we know how to do that pretty well. Okay, we can change policies, we can change our practices, we can change our resource flows, we can get a project going for a year or 2. Okay, that's not so bad, and that's important too. We need to look at the details and make those changes locally. But the place where I think you do your most important work is in the middle, in the area of relationships and connections, which are going to be emphasized throughout the next couple of days, and in the area of power dynamics. Because you are conscious of power dynamics and you're trying to shift them. Guess what? You're going to mess up. You're going to make mistakes. You're going to perpetuate inequities at times. But you're going to be open to learning and changing. And you're going to be open to moving aside when that's the right thing to do. But you're also going to be willing to take up space when that's the right thing to do. And that's maybe harder for many of us in this room. But I want you to take up that space because we really need you. We really need to hear your voices, each one of you. So in that middle space, which is very much underexplored in research, in practice, and in policy and advocacy, that's where you can do some real innovative and interesting work. You'll have relationships with one another. You have relationships with decision makers in the whole Public Health Agency of Canada. You have relationships with the KDE Hub who are there to help you share what you've learned. And you know a lot about the power dynamics and how we can shift power to the participants in your programs, but even to yourselves, right, as community organizations. So you are already doing much of this work. And I'm going to talk about a framework that I have been thinking about for a long time and working on and developing, and I've never shared with anybody until this morning. So I love to hear from you what you think, because I want it to eventually get leading us to common evaluation, common storytelling about the impacts that we're having. So you're doing the work of 4 Ps to go with those 4 Cs from today. You're working with people and communities. You're changing our public systems of health and social care. You're doing policy work, whether you think of that as your primary work or not, and you're doing it in place, and you're doing it in a relational way. So I'm a health geographer by training. I understand health as produced in relationships, relationships with the places we live in, the communities we're part of, with ourselves, with our families, with the land, and the other non-human inhabitants of this land, with the past and the future, and all imbued with those power dynamics that we're so sensitive to and able to change. We can change this, and you are changing this. Okay, so here's what it looks like right now. So in the middle, I just put 2 hearts. That's people, individuals, but also the bigger heart, the communities, right? We're in relationship. If we weren't in relationship with our environments, we would not be alive. If we weren't in relationship with other people, we wouldn't have mental health and well-being. I don't really love the term mental health. I don't think it encompasses what it is that you're doing around promoting that feeling of belonging, of meaning, of purpose, of humanity. But we'll go with mental health for the moment, okay? Because I'm a pragmatist too. Okay, so number 1, closest to the person and their relationships is people. And I didn't put person. I know we talk about person-centered care sometimes, and that's part of it, but it's the individual in relationship. And whether that's in relationship with a caregiver or a family member or the broader community or an even broader non-geographic community of identification, right, along the lines of your gender expression or identity, your sexual orientation, your diasporic community, and so on. You start with those health promotion principles, and I'll get into those a little bit in more detail, but this is the part that I think is really transformative and that you really excel at, right? Health promotion is the process of helping ourselves and one another to gain more control over our health and the conditions for our health and well-being, right? Shifting power to people to decide for themselves what matters to them, what goals they want to achieve, right? And to start with what's strong over what's wrong, that asset-based approach, that strengths-based approach. And to really root it in something that Indigenous health leaders have shown the way on, which is self-determination, that people get to decide for themselves what matters, that sort of psychologically, individually, and politically as communities. And there are a few components of self-determination that we can measure and we can have goals about and we can track and we can try to get to. So autonomy over our own health and healthcare decisions. Competence, a reminder that we can do this, we got this, right? Beneficence, our ability to give back to others. You know, we feel really good, and you hopefully feel really good about the work that you've done as part of this. When we give back to others, give back to our communities, we feel really good. And the one that matters a lot to me, belonging, okay, relatedness. That we know that not only that we have a friend or a community member, but that we're valued, we're heard, we're prioritized in policy and practice, we matter. Okay, so that's the people part. I think you're doing this really well. And you're gonna hear a lot of really good and inspiring stories from one another about how you're doing this really well. Okay, the next part, and this is where I think a lot of our sort of tracking and thinking tends to sort of stop. We influence our public systems. So that means we demonstrate for people who make decisions and spend money that we're helping them in some way. So in healthcare, we often use something called the quintuple aim for healthcare improvement. So that is improved population health, making people healthier, improved health equity, right? Have we improved health experiences, outcomes, and so on for people who are facing specific barriers, right? And we know who they are because the data is telling us, right? Black Canadians, African, Caribbean Canadians facing barriers, right? Indigenous people facing barriers, and so on. We can track that, we can measure that, and you have been selected because you're specifically working with communities that face barriers. So health equity. Improve care experiences for people. They just enjoy coming to mental health services more than they did before, or they get better access, more smooth access, and so on. The care team well-being, the staff, the volunteers, the workers, they have a sense of purpose and meaning in their work. They're not, drowning in paperwork. They're not burning out, right? Those are some important indicators. And there's, I always forget the last one in any list. Cost effectiveness, right? Efficiency. And that might not be something that we think about as a core value, but the work that you do, any kind of upstream health promotion work, it saves a ton of money. Like think about if all the things that you do now had been in place prior to the pandemic, how many millions of dollars we would have saved. Or if they were in place 40 years ago, right? So even though this might not be something that is directly important to the immediate work that you do, it's really important to the public systems that we're accountable for the work we do and we can demonstrate a really good, social return on investment. Okay, so moving past that to the parts where the scaling up really starts coming into play. Policy, okay, and my heart's in policy. I've done a lot of policy work over the years. That we use the learning and the evaluation cycles that we've got as individual projects and collectively to better connect what you're doing on the ground and the community members and community organizations to decision makers. Okay, so again, just having your funders in the room with you is part of that, right? You're doing your learning and evaluation in a cyclical way, and I'll show a diagram in a little bit about what they call learning health policy systems. So some of you might have heard of the term learning health systems, which is just the latest trend in, quality improvement and evaluation in healthcare. Making sure we all want to be learning and improving, that's a good goal. But it needs to, from my perspective, be linked to decision-making and policy. And then likewise, you hear about what's happening in policy and that breaks down barriers and opens things up for you. And then you can share new barriers and all the new challenges with policy, and then it goes, right? We learn from one another, and without that dialogue, we're not gonna be making good and effective policy. And our practices will stay as those little pinpoints across the country. Okay, and then the last one, and this is where the really more long-term and sustainable part is, that we're shifting power to community. And often, that really is in a place-based way. Like, we put our feet on the land, we know the other humans who live in our neighborhoods and communities, we take care of one another, we think in a long-term, really long-term way. And we do things like have sustainable funding, right? So we can measure that too. Have we employed a community health worker with expertise that wasn't recognized before, that maybe doesn't come in the form of a registered health professional certification, but comes from having trusted relationships in community, right? Or international designations. Have we invested in community health in a new way? Have we changed our own organization such that participants are now taking governance roles and making decisions about how money is spent? Or guiding evaluation, right? Or things like that. Are we shifting power to community? And are we doing it in a way that, again, alongside those efficiency cost arguments, is also more environmentally friendly, right? Like, if we're moving people upstream, if we're dealing and doing mental health promotion, we're reducing the number of healthcare visits, unnecessary interventions and tests, unnecessary medication in some cases. We're thinking about sustainability. And this year's report by the Chief Public Health Officer of Canada was all about resilient local place-based communities, being ready for the next pandemic or other emergency, climate emergency, heat, wildfire, smoke. We don't do that unless we have strong local infrastructure, and that includes our social infrastructure where you are. So we need strong, local, powerful stuff. We need to demonstrate that we've changed our funding and our power structures to make that happen. So I think I've probably mentioned all these, but these are some of the domains that I'm thinking about when I'm talking about people, the public system, policy in place. I think the one that I didn't really mention, what am I see here? Oh, under number 2, under the public system, that you've integrated social and healthcare, right? So that health includes all the action on social determinants of health as part of a health system, right? And so when Alice said, the term social prescribing keeps coming up for me, I like it because it's a tool that helps connect those systems together and helps us track what happens when you do that. What happens to people's health when you better connect them to community? Okay. So I'm gonna go into those 4 domains a little bit, and I want to just keep sort of mentioning those 4 Ps because I hope over the next 2 days you can keep 1 or 2 of them even in the back of your mind and think about, am I working on this? Is there some kind of measure that I already have in my toolbox that I could use that would demonstrate progress on this? So this one is the health promotion part. Most of you have probably seen this asset-based community development diagram. That movement from everything being done to us, without us, all the way through to by us, for us, right? And our jobs as project staff, funders, facilitators, researchers, is to provide support and to walk alongside people in their leadership on this. And this is where some of the indicators that you are already collecting or could collect in the future would be like, are we using strengths-based approaches? What demonstrates the ways in which community is taking leadership in our projects? Are we using anti-oppressive or trauma-informed or culturally safe approaches? How do we know? What do people think? If we think we're doing it, are we actually doing it? Are we as safe as we think we are? Right? And that's where we get into some of that meaning part that mental health promotion is so strong at, right? Trust, sense of purpose, meaning, joy, belief. I believe in you as a participant in this program, as a deliverer of this program. Someone else's confidence in you can be good medicine, right? All of this stuff can be really good medicine. And then like self-reporting, asking people what their own experiences, outcomes, use of services are. right? And validating those self-reports as legitimate health measures, that we don't just need to measure your HbA1c levels to know that you're feeling better, that you're doing better. Okay, so like I said, I read every single one, but I wasn't able to share every single one in this presentation. But I found examples of these 4 Ps in the work that you do. So, Acorn Family Place, are you here? Winnipeg, hi, I love your work so much. Okay, so I just grabbed these quotes from the KDE Hub, but we know that people are the experts of their own lives. We know that they have the capacity, every capacity and capability in the world to do what they need to do. That's no big deal for you, but it's transformative for most other people that you're going to be interacting with. But there are so many barriers that are put up in society that break down trust and relationship and safety. Like, way to go, Acorn Family Place. You got this. Okay, health promotion. Okay, in the public system, this is where I talked about that quintuple aim and the SDOH, social determinants of health. Also thinking historically, structural determinants, right? Relational determinants, and so on. This image is from The Lancet. And it just reminds us that mental health, showing the brains and all the people there, it doesn't just happen in our brains. It has social determinants, right? Demographic, economic, neighborhood, environmental events, right? And that's where you are doing really, really good works. Mental health has social determinants. I am part of the scientific advisory committee for the Health Inequalities Reporting Initiative of the Public Health Agency of Canada. And I asked them if I could tell you this, and they said I could, that they have a report coming out in June all about the social determinants of mental health in Canada. And I hope you love it. And I hope you also critique it and push it further, because it's creating space for you to do what you do, right? To put it out there that there is a connection between inequities in mental health and inequities in all these other things, right? That our mental health has a lot to do with whether we've got stable housing, or the population group that we belong to matters, or we face discrimination, or we're afraid we're going to face discrimination because we see what's happening in other places. Or we live in substandard housing or flood-prone communities, and climate events are happening. It's a hard life to live in insecurity and instability. And so much of our mental health is related to that sort of precarity. And it feels sometimes like precarity is increasing. There's a lot of uncertainty for ourselves. I think about my own 3 daughters and where are they going to live? What is their climate going to be like? What work that they want to do will be considered meaningful enough to build a life around? Will they have access to, right? And these are people who are growing up in relative privilege. And I want them to know solidarity. And I want them to know that in that process of building community and solidarity is where that rootedness and stability will be coming from for us in the context of other things that are beyond our control. Okay, Vanier. Uwe Vanier. Hi, Vanier. Social prescribing for kids. Oh my gosh, I visited Vanier and I talked to some of the kids and they were the best. Like, I just wanted to go for a walk in the forest. At a systems level, we're also seeing professionals and staff who are social prescribing at less risk for burnout, much happier and joyful in the work they're doing. Look how joyful Vanier is, right? That's not coming from nowhere. First of all, you brought the joy, so thank you. Secondly, it's reinforcing, right? You do good work, you feel good about it, and the cycle continues. And sometimes the antidote to burnout is not just less paperwork, although that is part of it. Sometimes it's a sense of meaning and purpose and feeling like you're doing what you thought you signed up for when you joined the world of health and social care. So showing that community according to the metrics that matter to them, that you're making a difference, it matters, right? So that idea of meeting people where they're at isn't just for clients and community members. It's also for decision makers, clinicians, and others, right? So that's why I'm okay with the term social prescribing, even though it sounds kind of medical, because it means a lot to clinicians who are going to be involved in it, right? And we can use evidence that matters to them, or health planners and decision makers, evidence that matters to them. Okay, so the learning health policy system, I'm not going to get into all the details, but the idea is better connecting what you're doing and what you're learning with those things, with what matters to those decision makers. And then them learning more about what matters to you, right? And continuing that cycle. Linking policy and practice, linking the particular and the general. So in public health, we often use that term targeted universalism, right? So it's like we have big goals that we want everyone to reach in solidarity. But we know not everyone requires the same strategy to get there. And sometimes those strategies are going to be very local and very place-based. And guess what? We have the sophistication to do that really, really well, right? We've got the technology, we've got the people, we've got the mindsets, we've got the heart. So we can do that. We can do this really disaggregated approach and collect disaggregated data about it and still show how we're moving towards some collective goals together. Like, that's pretty cool. And I would not be able to do any of the policy work that I do if I didn't talk to people and listen to people who are actually doing the work in community, which is why I'm really thrilled to be able to stay for a little while and hear more about you and what you're doing, so that I know what to keep advocating for. And to hear the challenges and develop empathy for the decision makers in the room and to know their context and how hard it is for them to push things through sometimes. And what uncertainties are around the corner with, elections and changes in the world. So learning health policy systems. Wanasa, are you here? Hello, Toronto. I grew up in Aurelia, which is a couple hours north of here. And you may have heard of, I'm getting off topic for a second. Okay, you may have heard the term Toronto to represent the traditional name for this place. It actually comes from the narrows between Lake Simcoe and Lake Couchiching in Aurelia, where there were fish weirs, which is wooden posts in the water used for net fishing, for over 5,000 years. And people came together, put down arms, allowed that to be a place of abundance and plenty and peace. And the Chippewas of Rama First Nation, who live there today and have lived there for a couple hundred years now, are the Minjikaning, the keepers of that fish fence. So when you hear Toronto and everybody thinks it's from this place, it's from pretty close. It's actually Aurelia. Okay, Minjikaning. Okay, sorry, Wanasa. Learning health policy systems. So one of the things that I really loved in the quotation from your work was the idea that these practices that we're learning about reach out to everyone. So we wanted to create a grassroots organization to address mental health, racial trauma, and intergenerational trauma. Okay, that time thing again. From a Black-centric lens, which includes therapy and collective wellness initiatives for caregivers, right? Those unsung heroes, their chosen families, and key members and leaders in the community to make sure trauma-informed practices trickle down to everyone. Right, so that learning happens and is shared, and then we want to take that learning and scale it up. Okay, and then the last one, place, right? And the place you do that is community. Oftentimes that's geographic place, and I think that land-based, place-based policymaking really matters. But of course, some of that happens across boundaries, and I know you're all tired of seeing each other on Zoom, like everybody's doing the Zoom box this morning, but it helped you meet some people that you otherwise might not have met before. And we all learned how to get online at the same time together, so it's not just the tech-savvy people and the rest of us. Like, okay, no, we can collaborate across Canada and around the world. And as the icing on top, we can be together sometimes too. This graphic comes from the World Health Organization's Commission on the Social Determinants of Health, way back in 2010. And don't worry about all the details on it, but the one thing that I wanted to point out is this one, community, the meso level, because it's the one that just, for some reason, got ignored, right? So we're not too bad at the micro level, individual interaction. The macro level, public policies, like folks in public health often say to me, the work you're doing is too local, like it's not impactful. We should only be doing big P, population health policy. And certainly that policy part is important. It's a big part of what I do. But it doesn't happen without that community knowledge and connection. And then there's that big globalization environment and all that global stuff that's pushing power around. But the meso level, the community, the policies that reduce vulnerabilities of people facing disadvantages, this is our time to shine. We can do this, and this is an area that is under-researched, or where it happens, again, it happens in sort of siloed and isolated ways, not collectively. So this is where we want to show investment and visibility, or like making visible those invisible parts, those relationships that happen in the community that take us beyond the building blocks, right? Those 6 building blocks that don't tell the whole story of what happens in health systems. That we build that resilient local infrastructure, that we think ecologically, and that we do that in a way that's historically informed, right? So that we know, like people accept social determinants of health now, but they don't ask questions about where they came from. So we just accept that this neighborhood has worse health outcomes than that neighborhood, but we don't think about what were the housing policies that led to this, right? Or the immigration patterns, or the discriminations and exclusions that happened historically and continue to happen now. Okay, so we gotta think historically, or none of this makes any sense. Okay, so I picked 2 for this one because I don't know why. I'm a geographer. I like the power in place part. So the Alex, are you here? Oh, hi, the Alex. Onesie. Nice to see you. Oh, twosie. Okay, good. Okay, good. With introducing Indigenous and cultural supports to the Alex in Calgary, it gives young people a sense of belonging and identity in recognizing their value in this space, which establishes that relationship of trust and value. Making space isn't just a conceptual thing. It can be an actual physical thing that we do. And that's what health and mental health are, right? They are the expression of our relationships, our social conditions, our political conditions, our environmental conditions in our bodies. When we see high rates of anxiety in young people, that's telling an important story about the conditions they're living under, right? So it's a physical thing. It's expressed, and those health outcomes tell us stories about what we need to change. Okay, Ghanaian Canadian Association, are you here? Hello. Thank you for the work you do that is local and in many communities across the country. It's going to be a train the trainer model where we train our community members who will then train their community members to be able to increase the capacity of our trainers. All our mental health support is in the community. I can't say that part enough, just in the community, in the community, in the community. So good. Okay. Right, so I just want to wrap it up by saying, I love you, you're the best, keep up the good work, stay true to what you're doing. Funders, help us with funding the policies, practices, and resource flows that we need. Thought leaders, keep thinking about and pushing us on better mental models. And implementers in the room, keep doing what you are doing. And I, for my part, will help to try to make it more visible, to celebrate it, to learn about it, to connect it to other parts of the systems, those relationships and connections that you're making, the power dynamics that you're shifting. Starting with people and communities, making changes that improve our public systems for everybody, connecting the work you do with policy, and shifting that power to community. Thank you again. I hope you have a fantastic next couple of days.
Well, Dr. Kate, that was phenomenal. Yeah.
Thank you.
On behalf,
Thanks so much. Oh.
On behalf of the KDE Hub and everybody here, Thank you for sharing. Can you hear me? Yeah.
I can hear you, but I don't know.
Your wisdom, your really pragmatic approach to how we can change systems, really inspiring vision, and your collective call to action. And, those things are going to frame our conversations in the next day and a half.